This episode of Doc Talk is brought to you by First Bank. We're not just your neighborhood bank, we're your neighbors. Our local team lives up to the name, putting our customers and community first. To experience First Bank difference, stop by any of our 13 Knoxville area locations or visit firstbankonline.com. First Bank, member FDIC.
Hello, my name is Dr. Rob Page, and I'm the host of Doc Talks. Doc Talks is a podcast that is run by the Knoxville Academy of Medicine for physicians, or actually by physicians of the Knoxville Academy of Medicine, to provide information to patients about topics of interest that are pertinent to them, be they topical or be they something that's fairly common. We try to address those. And today I have the pleasure of having with me Dr. Michael Antiporta. Dr. Antiporta is a general surgeon at Premier Surgical, and our topic for today is going to be hernias. Welcome.
Thanks for having me.
Excellent. So first things first, what's a hernia?
Sure. So this is the same kind of discussion I have with every patient who walks in my office, but a hernia is essentially a defect in the abdominal wall or sometimes in the diaphragm, but essentially it's a defect through which organs can protrude through and cause problems such as pain or organs getting stuck and the organ being threatened. Essentially it's kind of a lot of plumbing, just some things, a hole with an organ getting stuck through it.
So I remember when I was a kid, I remember one of the most uncomfortable parts of being a small child was you have a hernia check. Now that's a certain type of hernia, but there are multiple types of hernia. Am I correct?
That's right. So the first hernia we were discussing was an inguinal hernia, which is in the groin. But there are all kinds of hernias. If you had prior surgery, there's a chance of getting an incisional hernia. That's a subset of ventral hernias, which are essentially anything in the abdominal wall. There are flank hernias that are on the side, and you can have hiatal hernias in the diaphragm.
So essentially anywhere you have sort of a weakness in a wall and there's a chance that, your internal organs, usually bowel or esophagus or anything else that can come through that essentially is a hernia.
That's correct.
So now let's say I have a hernia. I've had a hernia for years. Do I have to get surgery for a hernia?
Well, it depends. Most of the decision making is based on, number one, how problematic it is for the patient, how much trouble it's causing them. The second thing is how dangerous do we think it's for the patient? So most patients who end up coming into my office who want a hernia addressed is because it's causing them pain, or it's a bulge that is maybe aesthetically displeasing to them. But for the most part, it's for symptoms or if it's something that could be dangerous to the patient.
So when you mention dangerous, what is the possible danger of a hernia that goes untreated, which may or may not be symptomatic?
Sure. So this is something we call incarceration. So when an organ, usually a piece of bowel, small bowel, might go through part of the hernia, it can become stuck. And if it becomes stuck and maybe becomes swollen, part of its blood supply could be cut off or the wall of the intestine can be compromised. And if that goes on for too long and you get irreversible damage, then it could cause a perforation. And then that could lead to need for emergent surgery.
So basically, if I need to have a hernia repaired, it's a preventative procedure that keeps me from having complications later on.
Yeah, it prevents the future complications, number one. Number two, it takes care of the pain symptoms we may have every day from it.
Most excellent. So, well, you mentioned some of the different types of hernia. And let's say that I come to you as a patient and I say, Dr. Antiporta, I need to have surgery, or you find that I need to have surgery for one of my hernias. So what does the surgery generally entail? Are there different types of surgery you can do for this? Is there if there's a one type, or would you recommend surgery in every instance? What would generally a consultation in a situation such as that entail?
Sure. So when a patient comes to me with a symptomatic hernia and we have to make a decision about what's the best way to approach fixing it, it's tailored to the characteristics of the hernia itself and also tailored to the patient. So for instance, the three ways really to fix a hernia is you can do it the old-fashioned way, open, you can do it laparoscopically, or you can do it robotically, and then there's also the options of whether there's something small enough that only suturing it would fix it, or if there's a question of if we need mesh. So for example, if I have a patient come into my office who has a groin hernia, and he's very active, who does a lot of heavy lifting and expects to and wants to continue that in the future, then obviously for that patient, you'd want something that's like the most robust and has the lowest chance of recurrence and can withstand the most stress. So for that patient who has an inguinal hernia, then for those patients, generally I'd recommend a robotic repair. If it's an elderly patient who maybe has a lot of other comorbidities, I would worry about being on the operating table a long time, or I worry about the negative effects of general anesthesia possibly, as far as like their heart or lung function. Then that patient might be a better candidate for an open inguinal hernia repair because it's less of a physiologic insult for them to be under local anesthesia, local or regional anesthesia, and then have the hernia fixed that way. And then as far as hernia characteristics, smaller ones sometimes are okay to treat with just sutures. For example, a ventral hernia that's less than 3 centimeters in size in a
So when you
patient.
say a ventral hernia, you're talking about.
Abdominal wall
Okay,
hernia. Yeah,
gotcha.
so those are like umbilical hernias or ones that are up and above the belly button, but very small ones where I don't expect a lot of stress on the repair. Then those might be reasonable to offer a sutured repair. Otherwise, generally we like to use mesh to really reduce the chance of these coming back.
Okay. Now I've heard about. Now you're mentioning certain types of hernia. Now, do you also do hernias for hiatal hernias, or do you also, or mainly talking about abdominal wall hernias?
Yeah, those the hernias I was talking about before, primarily ventral, abdominal wall, and inguinal. The approach to fixing a hiatal hernia is a little different. So those patients, their symptoms are typically reflux related, unless the hernia is so big that it becomes a subtype that we call a paraesophageal hernia, where part of the stomach can actually come up into the chest next to the esophagus. And those are the ones that we might worry about having an incarceration event where part of the stomach can come up, get trapped, or even twist on itself and compromise its blood supply, and that becomes an emergency. It's rare, but usually the patients who come to me with a hiatal hernia who have symptoms, we check them out to make sure that to see if they have this dangerous hernia or not, because the paraesophageal hernia is one that generally almost always needs to be fixed. Whereas a hiatal hernia, sometimes it's just the reflux that's causing symptoms. And in some instances, medication is acceptable.
And are the same options available for those kinds of operations as well, with the mesh or the suturing or even the robotic surgery?
Sure. Some of the nuances for those kind of hernias are a little more specialized. I find that fewer patients with hiatal hernias need some sort of mesh reinforcement. They are generally always done laparoscopically. It's very rare these days to need to make a big cut for those hernias, fortunately. I'd say it's standard of care to offer a minimally invasive approach for a hiatal hernia. And the robot is something that's a very nice technology to help enhance doing the operation also.
Gotcha. So I'm a patient and I come see you. Are there any reasons why I could not get a hernia repair? Are there certain things that should keep me, or certain things I should keep in mind when I come to see you about maybe not being able to get a hernia repair?
Sure, absolutely. So this is where patient factors come into play, because we want to always do the right thing for the patient and always help people. First do no harm. When I approach a patient who needs surgery, the idea is you go in, you want to do the best surgery the first time. So you want to give yourself the best chance that they'll have good outcome. So you want to address risk factors such as, are they smoking? And I ask all my patients to stop smoking for at least 4 to 6 weeks before surgery because of the impairment on wound healing it has as far as having a complication like a wound infection, and it can also contribute to hernia recurrence. Optimizing medical conditions like glucose control for diabetics. Weight is also a factor in affecting durability. So for patients who come to me who are heavier than the average, sometimes it's we have a long conversation about medical or surgical weight loss also.
So not necessarily would there be any reason for me to not be able to get the surgery, but I may need to do other things first before I'm a good candidate to get the surgery.
Yeah, that's right.
Excellent. Now you mentioned one thing, mesh, and I know mesh is one of those things. I've seen it on TV, and they've talked about different kinds of mesh used for different surgeries. What can you tell me about the mesh that's used for these surgeries?
Sure. So in general, all meshes that are used for ventral hernia repair are usually one of two types. They're typically made of polyester or polypropylene. These are the permanent meshes. They've been used by surgeons for decades in abdominal wall reconstruction. They're well studied. The instances of mesh complications that you hear about and that you see on websites, generally they're related to mesh use outside of abdominal wall reconstruction. But I look at it as any implants, any foreign body in surgery has risks of getting an infection or causing local complications. But it's similar to breast implants or an endovascular graft for aortic aneurysms. I think as long as the surgeon is adhering to best practices and using meticulous technique and doing safe surgery, um, then having a complication like that should be very minimized. And I think that that's true for all operations that involve implanting something to somebody's body.
So everything we hear about mesh isn't necessarily bad. These are actually devices that have been used, for these types of procedures for years and years and years.
That's right.
So
That's right.
excellent.
And the actual rate of these happening is, I'd say, far less than 1 in 1,000.
Most excellent. So I'm a patient. I've come to see you. I've quit smoking. I may or may not have needed to lose weight. Will this be something that my insurance will pay for?
Yes, yes. I mean, it's a medical condition. Generally, this is always covered by insurance.
Okay, I've had the surgery. What would I generally consider to be my downtime? So how much time would I need to think about taking off work? Or is that dependent upon the type of surgery I have, or?
Yeah, I would say that mostly depends on the type of surgery. Open surgery being the most invasive. So for somebody who may have had a recurrent incisional hernia with a large defect, that patient may require what we call component separation, which is separating the layers of the abdominal wall before putting them back together and sandwiching a piece of mesh in there to make it a more permanent, durable solution. Those patients may have a big, worst case scenario, could have a stem to stern incision and need to be in the hospital for a couple of days. There are ways to do that kind of an operation via a minimally invasive approach with a robot, which can shorten the length of stay to a couple of days. But as far as expectations for after surgery, I ask patients to really avoid lifting anything more than 20 pounds for 2 months. So there's a lot of physical activity restriction, but eventually, I mean, months down the road, they'll get back to normal. They may not feel back to normal until a couple weeks after the surgery, again, depending on how invasive their approach is. But if we're attacking a hernia with a robot or laparoscopically, probably within a couple days to a week, you're back to being able to do work.
So basically is dependent. Sorry about my watch there. So I thought I turned it off. I got too many electronics on me. But so intrinsically, it's based upon the type of surgery we're having. I may or may not be able to go back to work in just a few days, but I would have to limit my activity. And it's basically dependent upon how large the hernia is and how much surgery would need to be done.
That's right. That's right.
So most excellent. Well, we've gotten a lot of good information about hernias. We've gotten good information about what type of hernias they are, about the different approaches to how we can treat the hernias. And essentially, it's something that I, as a patient, would be able to come and consult with you with. I'd be able to get insurance for it, and I probably would be back to work, all things dependent, in not too long of amount of time. Why don't you give us some information about your office and where you are and how I could get in touch with you if I'm a patient and wanted to come see you to get a consultation or to visit you regarding my hernia.
Yeah, absolutely. I'm with Premier Surgical Associates at Fort Sanders. Our website is premiersurgical.com. Probably the easiest way to get a hold of me or someone in my group would be to go to our website where we have our contact information as far as phone numbers, and then appointments can be set up easily that way.
So, and then David will also include, there'll be something on the bottom of the screen, which basically gives you the information about how to contact Premier Surgical and how to schedule an appointment. Is there any additional information on the website that I could find, maybe about information about hernias, or?
Yeah, there are links to we have a hernia center, and there are links to for patients to find out kind of what to expect. Other good resources would be like from the America's Hernia Society has information on it, to SAGES, which is a minimally invasive organization I'm a part of. But there's good data out there, good information. Just I'd say obviously be careful about what you read on the internet. Yeah. But I think most of all, find a surgeon who you trust and can have a conversation with, because when the patient and the surgeon are on the same page and they know what to expect, then that's how we get the best outcomes.
Most excellent. Well, thank you so much for joining me here today. Is there anything else you'd like to add about hernias?
There's a fix for it.
So you broke, you got a fix. Well, and I'd like to thank you so much for joining me here today and talking with me about hernias. And with that concludes this episode of Doc Talks. Doc Talks is a podcast which is produced by the Knoxville Academy of Medicine, by its staff, using its members to provide information to patients about topics that are of interest to them. If you're interested in finding any more information about topics, come to the Knoxville Academy of Medicine website. There will be this podcast as well as other ones that you'll be able to come across. If you've seen this through another resource, and of course you can always go to Dr. Andy Porter's website to get Premier Surgical to get more information about hernias. And thank you so much for joining us here today.
This episode of Doc Talk is brought to you by First Bank. We're not just your neighborhood bank, we're your neighbors. Our local team lives up to the name, putting our customers and community first. To experience First Bank difference, stop by any of our 13 Knoxville area locations or visit firstbankonline.com. First Bank, member FDIC.